Hi guys, it's me again. I thought I would bring some of the science behind our last video and teach you some things that really are the reasons why I decided that I was excited about this stuff. So here we go. I don't get paid by drug companies. First, let's talk about diabetes and prediabetes as a preamble to this talk. And what I mean by that is let's get a little background to what diabetes and prediabetes is, at least in our clinics. And so we get the definition of diabetes in four ways, and they're all with blood sugars. Most commonly today, we use a hemoglobin A1C of 6.5%. You can do it with fasting blood sugar, random blood sugar, or an oral glucose tolerance test, but really it's the hemoglobin A1C of 6.5%. Insurance really uses that, have us document this for a reimbursement of medications. So it's pretty much the hemoglobin A1C of 6.5%. And where did that come from? I really just learned this a couple weeks ago. Hemoglobin A1C target actually came from when folks get diabetic retinopathy. Well, what really happened was international expert committee for the A1C back in 2009 reviewed all of the available data showing that for folks between a hemoglobin A1C of 6 to 6.7, in this study 6 to 6.9 or 5.9 to 6.2, they all started exponentially getting an increased risk of problems with their retina whenever we would do a fundoscopic exam. And what that means is we dilate your pupil and look at the blood vessels in the back of your eye. And diabetic retinopathy ends up causing blindness in diabetics, retinal detachment, and blurry vision even before that. And it turns out that this is mostly associated with changes in the blood vessel. Well, those changes are actually development of atherosclerosis in the retinal vessels. And so these are normal retinal vessels right here. We start to get some changes to the retina as we go forward, and to the point of growing new blood vessels and retinal hemorrhages. And so the difference between this and this is not profound. And this is old school medicine. And we've got better ways to figure out that folks are at risk for macrovascular complications like heart attacks and strokes, rather than looking at their eyeball vessels with our eyeballs. We actually have better technology these days. And so one of those things you've probably heard about or had is something called a CAT scan calcium score. And this is a CAT scan of our chest where we can look at the coronary vessels and see evidence of calcium. And where there's calcium, we know that there's atherosclerosis. And it may not be symptomatic, and so we call that subclinical atherosclerosis. And we can see this also in leg vessels. So this is a iliac artery ultrasound showing evidence of plaque formation. Again, it may not be symptomatic, so we call it subclinical atherosclerosis. And this is a carotid ultrasound showing us the same thing. And so the hemoglobin A1C of 6.5% is the diagnosis of diabetes. You'll understand why I'm teaching you this stuff by the end of this talk. By the way, the definition of prediabetes is the hemoglobin A1C of 5.7 to 6.4%. So remember, 5.7 to 6.4 was really right in the range where we started to see changes significantly to the retinal blood vessels. So moving on from that preamble, let's talk about Mounjaro and Zepbound. When we look at articles from places like the New England Journal of Medicine, which is really one of the premier medical journals in the world, it carries a lot of weight in the medical community. So here's a study from 2021 using tirzepatide, which is Mounjaro and Zepbound, versus semaglutide, which is Ozempic or Wegovy. And so head-to-head trial in type 2 diabetics. And so we started with a hemoglobin A1C in the 8.2% range, and you can see how those A1Cs fell with all of the medicines and all of the doses. Fasting blood sugar did the same thing. If we look at that same article, they also talk about a change in weight from baseline to 40 weeks. And there's a significant amount of weight loss associated with these medications. And also improvement in their lipid levels. If you'll remember our last video, we said the LDL cholesterol is the lard, and lard is never bad. Sorry, lard is never good. HDL is the happy cholesterol. We want the happy to go up and the lard to go down. Triglycerides, when those are elevated, that's a sign of insulin resistance, which is really what the physiology of diabetes is. Frequently in the clinic, I'll see triglyceride elevations about 4 to 5 years before I'll see folks get a true diagnosis of diabetes. So bottom line is this Mounjaro and Zepbound and Ozempic, it's all great for getting your blood sugar down if you're diabetic. Same journal, the next year in 2022, we see Mounjaro once weekly for the treatment of obesity, not diabetes, just obesity. So here's the breakdown of patients. About 65% were female. Most of them were in the moderate obesity to morbid obesity range. They really didn't have high blood pressure. Really, their cholesterols were pretty good, except their triglycerides were elevated. And about 40% of them were pre-diabetic. If you'll notice, their hemoglobin A1C was just below that cutoff of prediabetes at 5, which is 5.7 to 6.4. These were just below that. Same article. Let's look at the adverse events. Minimal numbers of patients and percentages had bad enough side effects that they had to stop the medications. The folks that didn't have to stop it, quite a few of them had nausea, diarrhea, or constipation. By far the most common side effect is nausea, constipation, or diarrhea. And refer back to the last video about how to keep those things from happening. It's basically don't eat fatty foods and try to stay hydrated and exercise regularly. Very few severe side effects, and kind of interest is when we would see patients back in the early 2000s get gastric bypass surgery, the severe weight loss would precipitate gallstones and they would have gallbladder problems called cholelithiasis, which is gallstones. And I'm a little surprised that there weren't more of those here. But bottom line, great for weight loss without surgery, without bariatric surgery, with really minimal side effects. Same medicine, same journal, 2 years later for the treatment of obstructive sleep apnea. So this is the apnea-hypopnea index, and an apnea-hypopnea index of 15 is considered moderate severity sleep apnea. So these drops in the apnea-hypopnea index are compelling. They're pretty great. So this is a great treatment for sleep apnea patients. This was the same medicine for the treatment of metabolic dysfunction-associated steatohepatitis with liver fibrosis. And there won't be a test about that name at the end of this, but we frequently call this fatty liver disease. And so if your doctor has ever told you about having fatty liver disease, this is what we're talking about. So these patients frequently have elevations in their liver function and on our regular labs. And you can see that with treatment with tirzepatide, their liver function tests went down. Also, the degree of fibrosis that was seen in these patients decreased. And this is really one of the first medicines to really do that. So fatty liver disease is the number one cause of a need for liver transplant these days. It used to be hepatitis C, but we pretty well cured that now with antiviral medicines. And so fatty liver disease is the next wave of liver abnormalities leading to liver transplant. So this is a great medicine for treating fatty liver disease. In my neck of the woods, they did a study that just came out at the end of January this year for heart failure with preserved ejection fraction. So if you had water on your lungs and you had shortness of breath with a normal squeezing function of your heart, they put these patients on a placebo injection versus tirzepatide, and there was a statistically significant decrease in the amount of heart failure in folks on tirzepatide. So we can keep you out of the hospital with HFpEF. What about preventing diabetes? So it turns out that this medicine also helps prevent diabetes. Late 2024 article in the New England Journal of Medicine. This is the change in body weight with placebo injections. And how did the folks with placebo lose weight? Because everybody was encouraged to change their diet and exercise, regardless of if you got the study drug or a placebo saline injection. And so the coolest part of this is that the incidence of type 2 diabetes just rarely happened over a 193-week follow-up period, as opposed to patients who took the placebo injection. 1 in 5, almost 1 in 5 of them ended up getting diabetes over the course of the study period. So we can actually prevent diabetes now, and that's what's compelling about this to me. So speaking of prevention, if we use the current AHA-ACC prevention guidelines, which came out in 2019, and apply it to our current patients, if you have a hemoglobin A1C greater than 6.5%, here's what our guidelines suggest. We give you dietary counseling, tell you to exercise, and then treat your blood pressure and cholesterol aggressively. And maybe we'll give you some metformin. And then we'll see you in follow-up. If your hemoglobin A1C stays less than 7, we're doing a good job. And nothing else needs to change. If your hemoglobin A1C doesn't respond to that, then we need to be aggressive with treating your CVD risk factors, your cardiovascular disease risk factors. And at that time, in 2019, which was before any of the trials I just showed you from the New England Journal, we would add Jardiance or Farxiga or a GLP-1 agonist. Our current guidelines are really not treating patients very aggressively, and we'll see why that's important here in a minute. And I mentioned cholesterol, and if you're a patient in my clinic, usually you're between the ages of 40 and 75. And if your LDL is greater than 190, you need to be on a statin. If you're diabetic, you need to be on a statin. And if you're neither one of those things, then we actually will do something called an ASCVD risk score. And if your risk score is greater than 7.5%, we recommend being on a statin. This gray area between 5 and 7.5, that's a good time to get either a calcium score or an HS-CRP level or an LP-a level, or any of these historic conditions. If you've got any of those things, we need to consider placing you on a statin a little bit more aggressively. And so this is how we currently decide to prescribe statin medications. If we are talking about prevention, here's what we know. Here's some data for you. In regards to the hemoglobin A1C, this is a paper that came out in 2021 out of Spain. And by the time folks had a hemoglobin A1C of 5.4, 50% of them already had evidence of subclinical atherosclerosis. So these are not even pre-diabetic. And by the time you reach prediabetes at 5.7, well over 50% of patients already had subclinical atherosclerosis. So why are we not being more aggressive in treating the risk factors when we learn that the actual diagnosis of diabetes only came from when we started seeing changes in the eyeball blood vessels? It's kind of crazy. We need to do better. And so that study broke subclinical atherosclerosis down into these parts. And you can push pause here on the video and see that folks could have barely any elevation in their hemoglobin A1C and had 25% risk of having atherosclerosis. And so this is pretty impressive. And this is why I personally got excited about getting aggressive once I got the diagnosis of prediabetes. Since 2017, 3 large studies were combined into what we call a meta-analysis for subclinical atherosclerosis. And so by the time you're pre-diabetic, these folks already have clinically meaningful atherosclerosis, and well over 60% of them already have subclinical atherosclerosis as well. And remember what we said about the cholesterol treatment with a statin, 190 or a history of diabetes. That's not being very aggressive at all. And so the ASCVD score really is an age-dependent risk stratification. And it's not aggressively treating folks who already most likely have subclinical atherosclerosis. So we need to get that large cholesterol down, and we need to treat our hemoglobin A1C, which is a sign of our insulin resistance. We need to be more aggressive with this, and here's why. 25 years from now, the amount of diabetes, hypertension, and obesity are just going to exponentially increase, and the cost of taking care of this already high, and it's going to get exponentially higher. So we need to spend a little bit of money now to save a lot of money going forward from a healthcare prevention perspective. So we call all of this cardiometabolic health, and we need to do a better job with cardiometabolic prevention. And I hope this was a little bit enlightening for you. I hope that you find this as impressive as I do. If you want to read each of these studies, I'm actually putting a hyperlink for each of these studies into the description below. If you have any questions as far as, hey, Riley, I wonder about this or that, just either send me a message at work, or you can put a message here on the YouTube channel. And if you have any other insights that you wanted to share with me, please feel free to do so. I look forward to doing the next video about patient assistance programs and how we can help ourselves get medications that we otherwise couldn't afford. So look for that video to come in the near future. I want you all to have a great day. Thanks for listening.